which we are going to begin from today, the eye to eye online case presentations. So today we will be presenting with 3 cases, 2 anterior segment and 1 posterior segment. The 2 anterior segment cases are primary open angle glaucoma by Dr. Stuti, and Dr. Gautami would be presenting corneal ulcer, and Dr. Tejas would be presenting the case of retinitis pigmentosa. We have 3 esteemed guest faculties who would be our examiners today. We have Dr. Jayashree. She is a senior professor in Bagalkot Medical College, SN Medical College, Bagalkot. And we have Dr. Anupama, who is a professor and HOD from SDM Medical College, Dharwad. And we have Dr. Apurva, who is a vitreoretinal consultant from Joshi Eye Institute, Hubli. So we welcome all the examiners also who are present with us. So with this, we wouldn't waste much time. We will go ahead with the first case presentation, which would be Dr. Stuti from Joshi Eye Institute, Hubli, who would be presenting her case on primary open angle glaucoma. Request to all postgraduates, any question you have, I have opened up my YouTube link also. So any questions which you have, you can post it on the YouTube link. I would be taking up that questions by the end of case presentations with the examiners. So Dr. Stuti, once you present the case, I think we will open up for the examiners as to how they would be asking you the question and how it would be going on further with your Viva Voce part. So over to Dr. Stuti for POAG case presentation.
Hello. Good evening, everyone. Am I audible, ma'am?
Yes.
Good evening, ma'am. So I'm here to present a case of a 52-year-old male, businessman by occupation and a resident of Hubli, who came to the OPD with the chief complaint of diminution of vision for distance and near in both eyes since the last 5 months. So the patient was apparently all right 5 months ago when he developed diminution of vision in both eyes, which was for distance as well as near, and it was insidious in onset and gradually progressive and painless. There was no history of usage of any glasses, no history of any associated ocular symptoms like pain, watering, redness, flashes, floaters, distortion of vision, or any headache. There was no history of any chronic medications, topical or systemic, no history of any previous ocular injections, procedures, or surgeries done, and no history of any trauma. There is, as a personal past history, the patient is a known case of hypertension who's been taking beta blockers since the past 2 years. There is no significant family history, and the personal history is also normal with a mixed diet, good appetite, adequate sleep, and normal regular bowel bladder habits. On moving to the general examination, the patient is moderately built and nourished, conscious, cooperative, and well-oriented to time, place, and person. His vitals are all normal, pulse 80 beats per minute, respiratory breath 18 breaths per minute, and blood pressure 130 by 78 millimeters of mercury. There are no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On systemic examination, the cardiovascular, respiratory, nervous, as well as per abdomen, all are within normal limits. Coming to the ocular examination, so the right eye, the visual acuity of the patient unaided was 6 by 24. On pinhole, it was not improving, and the near vision was N12. So the best corrected visual acuity for the patient was 624 N12. In the left eye, the visual acuity was 6 by 12 parts, which was not improving on pinhole or on acceptance, and near vision was N8. So the best corrected visual acuity was 612 parts, N8. The head posture, facial symmetry, and ocular alignment of the patient was normal.
Stuti,
Coming to the right.
Second.
Yes, ma'am.
Can you briefly, before going to examination, can you briefly concise your history? On history, what you have diagnosed?
So
your differential diagnosis on history.
Yes, ma'am. So the patient is a 52-year-old male who has come with the chief complaint of diminution of vision for distance and near in both eyes since the past 5 months. It is painless, gradually progressive, and there is no any associated ocular symptom or no history of usage of glasses or any medications. The patient is a known case of hypertension, and there is no significant family history as well. So considering that it is a 52-year-old male having diminution of vision for both distance and near in both eyes, which has been painless and gradually progressive, the possible differentials are most commonly could be cataract, so senile immature cataract. It could be any refractive error. The patient could have any glaucomatous changes like a primary open angle glaucoma or a closed angle glaucoma. There could be any macular or retinal pathologies, but the patient is hypertensive. So probably some hypertensive retinopathy, but they would less likely present with sudden, this kind of diminution of vision. And the patient has been taking medications properly. Any other? Yes, ma'am.
One thing is that refractive error at age of 52, that should not come up. Okay,
Yes,
cataract is fine.
Hmm.
Open angle, then you can go. If you think of open angle, any other history you want to ask? Any other history you want to elicit? Thinking of POAG in mind?
So with POAG in mind, ma'am, the age of the patient is generally
Any
more.
other history you want to elicit now,
I asked
retrospectively?
about a history of glasses because POAG is more common in myopes, but there is no history of usage of glasses.
Apart from
Patients
myopes,
are normally
anything else?
diabetics.
No, apart from myopes, glasses, any other thing you elicited regarding spectacles?
A frequent change of glasses, ma'am, normally.
Which glasses? Frequent change of which glasses? Like for near or distance?
Ma'am, from what I have understood, that the patient is not really comfortable with the prescription that we give for near as well as distance. So they don't end up coming to a conclusion as to what the pathology is. So they keep going to the ophthalmologist and keep asking for a frequent change of.
Frequent change, and especially they will have a near vision, presbyopic glasses. Frequent change of presbyopic glass. That is one of the symptoms. Otherwise, it is symptomless. Glaucoma,
Okay, yes, ma'am.
angle, it is frequent change of presbyopic glasses. That you should try.
Presbyopic glasses.
Okay.
Okay, ma'am. Yes,
and
ma'am.
other thing like differential diagnosis when you talk from anterior common age you have to consider, and things whatever progressive loss of vision, painless. So according to age and from anterior to posterior you go. Then you will not miss anything. Okay.
Yes, ma'am.
From anterior to posterior. From cataract, now glaucoma, then anything vitreous, retina, like that you go, you will not miss anything. Okay.
Yes, ma'am.
Proceed.
So, ma'am, should I go to the ocular examination now?
So these things I want to discuss.
Yes, ma'am. The ocular examination, the right eye, the adnexa and lids were normal. The conjunctiva was normal. Cornea was normal in size, shape, luster, transparency, and sensation. And the iris was normal in color and pattern. The pupils were round, regular, and reactive to light, and RAPD was present. The lens was clear. The intraocular pressure measured with Goldman applanation tonometry at 10 a.m. was 28 millimeters of mercury, and the ocular movements were full in all directions. And ma'am, the data provided also included that the central corneal thickness was 540 microns.
Okay.
Coming
You
to the
told
left eye.
RAPD, right eye
Yes, ma'am.
RAPD. So how you elicit RAPD?
So, ma'am, the patient is made to sit in a semi-dark room, and the patient is asked to focus at a distant object, and using a point source of light, keeping a cover in the middle between the two eyes to ensure that the light doesn't go on to the other eye. We do a swinging flashlight reflex, and when there is a paradoxical dilatation of the pupil in response to the light, that is known as a relative afferent
How
pupillary
many
defect.
seconds you have to swing? How quick? Within how many seconds you have to?
Ma'am, I'm not sure, but if it is 3 seconds.
Less than 2 seconds. Okay.
Less than 2. Okay, ma'am.
Then how do you grade RAPD?
So, ma'am,
I'm preparing you for exam.
Yes,
okay?
ma'am. Yes, ma'am.
These things you should know. Like, how do you grade RAPD?
So, ma'am, grade 1 RAPD shows an immediate constriction, but followed by a greater redilatation. No, sorry.
No,
sorry,
this
ma'am.
I will just give questions. You note down and you prepare for your exam. This thing, okay?
Yes,
and any
yes,
quantitatively, how you know RAPD?
Quantitatively, ma'am, using neutral density filters. So we put the neutral density filter in front of the normal eye, and we perform the swinging flashlight reflex till the RAPD is not seen in the affected eye.
That they will ask quantitative analysis. Okay. Next. Okay, you can go ahead.
So
what is the role of corneal thickness? You told corneal thickness they have mentioned in that.
So, ma'am, there are two things. One, when it comes to the measurement of the intraocular pressure, many times in thinner corneas, we tend to get a variation in the pressure. We end up getting a lower value. And
Yes.
also, patients with a thinner cornea are more likely to have a higher intraocular pressure. So, because of both these things, it is important to have a CCT corrected intraocular pressure.
Yes, very good. Go ahead.
Coming to the left eye, the adnexa and lids are normal. The conjunctiva was normal. The cornea was normal in size, shape, luster, transparency, and sensation. Iris was normal in color and pattern, and the pupils were round, regular, reactive to light. The lens was clear. The intraocular pressure with Goldmann applanation tonometry at 10 a.m. was 24 millimeters of mercury. The ocular movements were full in all directions, and the CCT was 545 microns.
Okay.
Ma'am, a gonioscopy picture was shown. Should I share and show the gonioscopy and the disc image, or should I just
Yeah.
describe it?
You better put that picture and you
Okay.
can.
Yeah,
that will
I'll
be
just
great.
share my screen.
Yeah.
Ma'am, once. So, ma'am, this was, ma'am, are you able to see my screen?
Yeah.
Yeah. So, this was the
One more thing,
gonioscopy. Yes, ma'am.
intraocular pressure you mentioned. Intraocular
Yes,
pressure.
ma'am. Yes, ma'am. The right eye intraocular pressure was 28 and the left eye was 24 millimeters of mercury using GAT.
Okay. GAT and timing also it is very important. That time
Yes,
you
ma'am.
have
At
to
10
mention.
a.m. At 10
Okay.
a.m. Yes, ma'am. At
That
10.
is when you are trailing and no shortcuts. Of
Yes,
mercury. Okay. Then timing is very
yes.
important and which instrument you have used that you should mention.
Yes, ma'am. Using
Okay.
Goldmann applanation tonometry at 10 a.m. 28 millimeters of mercury in right eye and 24 millimeters of mercury in left eye.
Okay. Then gonioscopy findings. Can you tell me the gonioscopy?
Ma'am, on gonioscopy findings, the posterior trabecular meshwork was seen in all the quadrants in both the eyes. So both eyes, the angles were open.
Okay. So they will ask in exam, they will ask about gonioscopy. No? What is direct
Yes, ma'am.
gonioscopy, indirect gonioscopy? What are the gradings? How you grade a gonioscopic angle? What are the abnormalities? What you find? Huh? So all these
Yes, ma'am.
things you should be prepared. Huh?
Yes, ma'am.
Gonioscopy. Gonioscopy itself is one chapter. Okay. So that
Yes,
all
ma'am.
gonioscopic changes in open angle, what all structures you see, how do you grade a angle? Okay. And any abnormal things if you note it's noted that you should to mention. Okay. So
Yes,
those
ma'am.
things you should be perfect while presenting the case. Okay. Next.
Ma'am, next coming to the fundus evaluation. So, the on distant direct ophthalmoscopy in the right eye, red glow was seen, and on slit lamp biomicroscoping using 90D lens and indirect ophthalmoscopy using 20D lens, the media was clear. The optic disc was vertically oval disc, which was normal in size and shape, with a vertical CD ratio, cup disc ratio of 0.8, with a concentric thinning of the neuroretinal rim with pallor, and there was nasalization of the vessels seen. The foveal reflex was present and the background retina was normal. And coming to the left eye, again, the distant direct ophthalmoscopy showed red glow, and on slit lamp biomicroscopy using 90D lens and indirect ophthalmoscopy using 20D lens, media was clear. The optic disc is a vertically oval disc, normal in size and shape, with well-defined margins, with a vertical cup disc ratio of 0.8, with temporal neuroretinal rim thinning along with pallor and nasalization of the vessels. The foveal reflex was present and the background retina was normal.
Okay. So when you describe the fundus disc, this indirect or 90D, which is better? Indirect ophthalmoscopy or 90 diopter?
Ma'am, 90D is better because it will give us a greater magnification
Yes.
compared to the 20D.
So that is important. And when you see they will ask you what are the early changes, early glaucomatous suspect. Okay. What are the early glaucomatous? When you suspect disc change?
So, ma'am, normally each
factors.
disc is supposed to follow the ISNT rule, that is the thickness, inferior, superior, nasal, and temporal, decreasing order of thickness of the neuroretinal rim. So, when the isn't rule is not followed, when we start seeing nasalization of vessels, when we see the bend of the vessels, that is a bayoneting sign, or bearing of the circumlinear vessels, that is because of the damage to the glial tissue, the underlying circumlinear vessels start becoming more prominent. These are all signs of
Early
glaucomatous disease.
glaucomatous changes. This is like it is evident. So when you see this thing,
Yes, ma'am.
you will tell it is evident of glaucoma. In early, when you suspect, disc suspect.
Ma'am, when there is a increase in the cup disc ratio, and and there is in the early signs we have nasalization of the vessels. There's a laminar dot sign which can be seen.
Those are late little. Asymmetry of the cup. Okay.
Yes,
How
ma'am.
much it should be? Asymmetry of
More
the
than
cup.
0.2, ma'am.
Yeah. So that is the earliest. Asymmetry of the cup is there. And also when you are seeing cup, disc size is also very important. In myopes
Yes,
and all,
ma'am.
you have a very big disc. And in
Large disc.
hypermetro, small disc. So disc size is, you have to relate with the disc size. So that is very important. Disc size and what is the cup CV ratio. So disc size is
Yes,
first
ma'am.
thing is, in myopes you have a larger cup. So it is
Larger
not a
disc.
glaucomatous cup. So that, and
Yes, ma'am.
early stage you have a asymmetry.
Asymmetry of the
Twice.
cup.
That is very important. Laminar dots and all, it is later.
Later.
Okay.
Okay.
And they will ask you what all are the glaucomatous changes, disc changes. One is you have mentioned, bayoneting you have mentioned, bearing you have mentioned, nasalization you have mentioned, vertical. But why vertical oval it is? Glaucomatous cup. Why vertically it will elongate, not horizontally? Is there
Ma'am,
any
the
reason?
superior and inferior tend to get affected more. The superior and inferior poles get affected earliest. So, and that is
Why?
why we have a horizontal cup and a vertical. Ma'am, because the supporting glial tissue is lesser in the superior and inferior. So the affection of the glaucomatous changes is seen first in.
And also the nerve fibers are more superior and inferior. No fibers. Okay, that is one of them. So any other this thing? NRR is very important. What other changes you will observe in early stages? One asymmetry I told. Anything else?
Ma'am, RNFL defects can be seen.
Okay.
Retinal nerve
Yeah.
fiber layer defects.
How do you see that RNFL defects?
Ma'am, using the red free filter, we can see the defects in the peripapillary area. The
Wedge shape defect, all those slit defect and all. Where any other condition you get a wedge defect?
Not sure, ma'am.
And one more thing is notching. Notching is very important.
Yes, ma'am. Yes, ma'am.
That notching you have to observe. Notching. Then NRR thickness in all four quadrants. Any peripapillary changes you know?
Peripapillary atrophy, ma'am. Commonly, the beta zone gets affected. The
you
beta
have
zone and the
alpha
alpha
and
zone.
beta zone. So that
Beta
also
zone.
you should observe. Okay, that is very important. Okay. So they will ask you disc changes. What all are the early changes, later, older this thing, established changes, all those things. Okay. Go ahead.
Ma'am, I'll stop sharing the screen.
Okay. Any other investigation you have done apart from gonioscopy and this thing? Any other thing?
Yes, ma'am. I'll share it again. They have given a perimetry reading. Just a second.
Before perimetry, anything else you have done? For early cases, glaucoma, pre-perimetric changes. What all are the pre-perimetric changes?
OCT RNFL can be performed in a pre-perimetric glaucoma.
So OCT.
But I mean, that data was not provided, but we can do in a. Yes, ma'am. OCT RNFL can be.
When you will get the field defects? How much
ma'am, only after almost 35 to 40% of nerve fiber layer damage only then shows perimetric changes.
Yeah. So that's why pre-perimetric changes. What all are the pre-perimetric changes, you know? What all you will observe in pre-perimetric changes? In OCT?
Ma'am, you mean in the OCT?
OCT,
ma'am, we look for the thinning of the RNFL, the NRR, and we have the Tisnet map
Yeah.
So that will show
Yes,
us each
graph.
quadrant, the amount of thinning that is present. And it is
Okay.
all normative data. So compared to the data that is available on the machine for the same population and age group, we can compare and know if the NRR thickness and even the ganglion cell thickness and all, whether
Yeah,
it is.
GCC is also important. Okay. Those things you should observe. And one more thing is even OCT angle. So OCT, anterior segment OCT. That also you can,
ASOCT.
yeah, AS OCT, and you can observe angles also.
Angles,
Angle,
yes.
position of lens, all those things can be observed. Those also will
Yes.
help you in diagnosing. Okay. Angle of
Yes.
opening is there or not. Is
Opening
there any,
distance.
any lens abnormality or any pushing mechanism,
Yes.
especially in cases of closed angle
Angle
glaucoma.
closure.
So pushing, pulling mechanism, those all can be
Yes.
observed in the ASOCT. Okay.
Using anterior segment imaging.
Yeah. Okay.
Yes, ma'am.
This,
My provisional diagnosis
this
is bilateral.
OCT, this field, this thing, Humphrey field, you can read.
Yeah. Ma'am, in the exam, when they give us the case, we have to talk about the perimetry before like, is it considered as an investigation that we would do after we give the diagnosis?
So
or
after diagnosis, yeah, after diagnosis, yeah, after diagnosis. You once you examination has been done, then you will tell your provisional diagnosis. What is your diagnosis? Then to assist to get a diagnosis, what you have to do? You have to do investigations. So that time, all these matter of investigation you will mention. Okay.
Yes.
Diagnosis should come after examination part. Okay.
Yes, ma'am. So, ma'am, my provisional diagnosis is primary open angle glaucoma and presbyopia in both the eyes.
Okay.
To further consolidate my diagnosis, I would like to go ahead with first confirming about the intraocular pressures. So instead of a single reading, I would like to do a diurnal variation of the pressures. So go ahead with a DVT. And after that, since in this visit we've already dilated the patient, so on the next visit, I would like to call the patient for a perimeter evaluation.
Okay.
So on perimetry, so this
One
is
more thing I wanted
single.
to ask, what is the role of DVT? This diurnal variation. Can you tell me?
So, ma'am, in some cases, if the DVT, in many cases, when we have a little borderline pressures also, the DVT will tell us the maximum range up to which the pressures are going up to. And especially in the DVT, if we have a variation of more than 8 millimeters of mercury throughout the day, then that also becomes significant. And it will also help us with respect to our treatment protocol as to when the pressures are spiked.
To dosage, to put a dosage, which time we have to put. For that also it will help. And it is not only done in early cases. Okay, it is done even to, it's not done only in early cases of glaucoma, to glaucoma suspect like that. So in between also, when you want to shift, when you want to change the dose, drug therapy, that time also you have to do, after sometimes even after surgery, you have to do and then see the variation and you have to introduce some newer drugs. Okay.
Because IOP fluctuations can also cause
That is
disc
very
damage.
important to put your drug dosage. Okay.
Yes, ma'am.
You can read this.
So, ma'am, I'll describe the chart. So, this is a single field analysis of a patient of the right eye, 69-year-old, taken on the 22nd of May. It shows a central 30-2 threshold test with CETA standard. The false negative errors are a little high, 26%, but otherwise we can consider it to be a grossly reliable field with only 2/20 fixation losses and 0% false positive errors. So a patient has been given near vision correction, and on seeing, we can see multiple depressed points of sensitivity as a superior as well as an inferior arcuate scotoma, together forming almost like a double ring scotoma. And the pattern standard deviation also highlights all the deep scotomas which are visible. The glaucoma hemifield test is outside normal limits, and the VFI is 66%. So all these findings, the mean deviation is minus 15.47 and pattern standard deviation is minus 10.92, which is less than p-value less than 0.5%, which is all of these findings are suggestive of the patient having a glaucomatous disc damage.
Okay. So how, what do you mean by this? Whether fields are reliable or not, how you will know? Reliable fields or
So,
not?
ma'am, normally the fixation losses and
Losses.
the false
How
positive
do
and
you
negative.
monitor fixation losses? How do you monitor?
Ma'am, obviously the person who is doing the perimetry is supposed to keep an eye as to whether the patient is fixating,
Okay.
and the patient has to be explained well about how to do the perimetry test, and to monitor that many machines have a gaze tracking system, so
Okay.
that shows a graph at the bottom of
Okay.
the chart, which will show you the peaks which are suggestive of when there have been sudden changes in the fixation, which indicates that it is not a very ideal perimetry recording.
Okay. One more thing, blind spot they consider. They put a
Yeah, yes, blind spot
what is
mechanism.
so that is also important.
Hmm.
What do you mean by false positive and false negative errors?
Ma'am, false positive is when the patient has pressed on the trigger even when a stimulus was not shown to the patient, basically like in case of a trigger happy patient.
Happy
And false, so when we get white out perimetry chart is what we would see sometimes. And a false negative error is when a patient was previously shown a particular stimulus and the patient had responded to it, and now even at a suprathreshold stimulus patient is not responding to that same sense point of sensitivity, which is suggestive of a false negative error.
Okay. So these parameters are important. False positive, false negative, and fixation losses. Pupil size and age. Age is also
Yes.
important. So this pattern deviation, all these things you should know how to read in the exam. Okay. So they will
Yes,
ask you what is scotoma, what is positive scotoma, what is relative negative scotoma. What do you mean by positive scotoma and what is negative scotoma?
positive scotoma is when a patient can see a dark spot within the visual field, whereas a negative scotoma is just the absence of the uh, object within the visual field. Like it isn't a. I'm not sure if I've explained it
Those
correctly.
things you should know. What is relative scotoma? What is absolute scotoma? You just note
Absolute
down what
scotoma is
uh,
absolute scotoma is when the patient does not respond to a particular stimulus at any intensity. Whereas if a suprathreshold stimulus is given and the patient
that
responds
is
to it, then it's called a relative scotoma.
positive and negative. This also you find out. What is positive scotoma? What is negative scotoma? These all are like exam questions. Okay. So they
Yes,
will
ma'am.
ask you in this. Okay. Then next, how do you
Um,
manage?
hmm.
Now you have done a
So,
diet.
ma'am, so for this
One
patient,
second, Dr. Anupama. Dr.
Madam?
Anupama?
Yeah, I'm here only.
ನೀವು ಕೇಳಿ ಮ್ಯಾನೇಜ್ಮೆಂಟ್
Yeah, ಇಲ್ಲ ನೀವು ಕೇಳ್ತಾ ಇದ್ರಿ ಅದಕ್ಕೆ I was just
no,
listening. Yeah.
you should not go this way. You also
No,
ask
no,
because
carry on.
they like different
Yeah, please
examiners
tell.
will have different questions, tough questions. So I
Correct,
want
correct.
you also to involve to ask
Surely,
questions.
sure.
Yeah.
Yeah, tell Dr. Stuti. You told how will you manage
yes,
this
ma'am.
patient now?
So, ma'am, now that I've confirmed that it is a primary open angle glaucoma, and after quantifying the intraocular pressure, I would like to come to a target IOP, which I would like to achieve for the patient, since the patient has a high, advanced glaucomatous disc changes. So I would like the patient to be very well controlled at a lower IOP. Also, considering the fact that patient is already on beta blockers orally, so I would also consider that about some percentage of my reduction in the IOP that is measured could have been because of IOP reduction because of systemic beta blockers as well. Considering that, I would like to start the patient on medical management of glaucoma first. The drug of choice would be prostaglandin analogs. And after I would have to supplement the prostaglandin analogs with another class of drugs as well, like an alpha agonist, because the patient is already on systemic beta blockers. And we try to follow up the patient
What is the
to get.
advantage of alpha agonist here?
Ma'am, the alpha agonist is considered to be the drug of choice because it causes good amount of IOP reduction, almost up to about 27 to 35%, and
Anything
also
other than
it
that?
will help decrease the uveoscleral outflow. Because of that, we will have a good IOP control. And it is a drug which only needs to be given once at night, once at bedtime. So we can expect good compliance also from the patient. So,
Which prostaglandin analog would you like to start? What are the different
Uh,
types of prostaglandin
Ma'am,
analogs available?
latanoprost, travoprost, bimatoprost.
Percentage? Yeah.
So latanoprost is 0.05%, travoprost is 0.04%, bimatoprost is 0.03%, and
The newer
yeah,
one, do you know? Pimetoprost, another one is available, no? LS, lower strength,
lower strength. Ma'am, I don't know the strength of the drug.
0.01. What is
Okay.
the advantage of lowering that, and what are the major side effects of these prostaglandin analogs?
Ma'am, the major side effect is it causes increasing the length of the eyelashes, hyperpigmentation, periocular hyperpigmentary changes, and it can also, I mean, it is a pro-inflammatory drug, so it can not be given in cases where there is any uveitis or any underlying inflammatory condition present in the patient. So those
Yeah, see, those
become.
other side effects, they may not
Hmm.
have any problem, but the major thing is hyperemia. Okay,
Hyperemia.
conjunctival
Okay.
hyperemia.
Hmm.
That is one of the
Among
reasons
the
why they discontinue.
prostaglandins, which one is better, like in controlling IOP? Travoprost, bimatoprost, and your latanoprost. Which drug is better?
Ma'am, I'm not sure within the class of drugs which is the best one.
There are studies, so that you should know.
Okay.
Like whenever anything you present, you should correlate with some studies will be there. Research studies,
Okay,
drug
ma'am.
studies, or any clinical feature studies. That studies also you should go through those things.
Okay. Yes, ma'am. Yes, ma'am.
In among the prostaglandin, which one is better? That you should know.
Okay. Ma'am, latanoprost is, I think,
That is commonly used, but lowering IOP, that is
because the
important.
side effects, I think, are the least in latanoprost. But I think travoprost, maybe. I'm not sure.
That's what you go through those things. Okay, note
Yes,
down what
ma'am. Yes,
I'm
ma'am.
asking. You will just go through
Yes.
those things.
Yes, ma'am.
When do you decide to add a second drug? When do you decide to add a second drug? Second drug, third drug, fourth drug. How do you decide that you need
Ma'am,
additional therapy?
when we call the patient for follow-ups and when we check the intraocular pressure and we are not able to maintain it with the drug which has already been there, or there are side effects, intolerable side effects to the existing drug and the patient is not tolerating, then we might have to shift to another drug. Or even if
Now,
the
the main
intraocular
question
pressure
is,
is normal, but if there is progression in the disc or there is progression which is noted on perimetry, then again that means that we need to further lower our target IOP itself. So in those cases, we will have to add another drug.
up to a maximum of how many drugs can you give in medical line of therapy?
Ma'am, I think up to 5. That is also a little too much because the patient will not be able to tolerate the multiple adverse effects of all the drugs added up together, especially like brimonidine and all the conjunctival hyperemia, allergic response and all. It will be and quite a economic burden also for the patient to be on 5 drugs throughout the day.
Okay, that is
So in
one
that
thing. The
case, we
other
can
thing is when
switch
this
to
patient comes, when this patient comes for follow-up, what type of visual field you will ask for in the subsequent visit when they come?
So, ma'am, firstly, it is always better to ask the same perimetry that we have asked in the previous one. Only then we can compare between the two. But however, if we have done 24-2 and we see that it is encroaching towards the macula, then we would have to go for a 10-2 or macular programming to see if there is any fovea threatening involvement.
So usually 24-2 is also more than enough. Even for your
Yes, ma'am.
progression analysis also, the same one can be
Yes,
repeated.
ma'am.
And when we do that 10-2, we always do point-to-point analysis. Like individual point, we look for how much decibel
How
loss
much is
has
the...
been. So
Yes,
point to
ma'am.
point, we'll be checking for that. Okay.
Yes, ma'am.
And one more thing is like target pressure. So how do you set the target pressure? There are formulas and what factors you consider. Target pressure, how that is also asked in. How do you set the
Yes, ma'am.
target pressure? So it is what do you mean by target pressure?
Ma'am, target IOP is the IOP range which we aim to achieve, so that within which there will be no further progression of the glaucoma that is noted. So this target IOP is based on we depend it based on the age of the patient. If the patient is very young, we would have to keep a lower target IOP. Then again, if there is progression is much faster, then again we should have a lower target IOP. And other associated cases, like if the patient is one-eyed, for example, and he has already lost another eye to glaucoma, then we would like to have a very close follow-up and a lower target IOP for this eye. And secondary glaucomas, which are much more aggressive in their course. So for them also, we would prefer to have a lower target.
It is like a customized this thing, and family history also plays a very important
Family history,
role.
yes, ma'am.
Family history. That also should
Yes,
be
ma'am.
considered. Age and how much damage is there. So visual field and disc,
It's a
whether mild,
yes, ma'am.
moderate, severe. So depending
Severe.
upon that, you have to, and also there is a formula also that you should know. When you are writing theory,
Okay, ma'am.
that formula is there. Visual field score and formula is there. That formula you should know how to set that.
Okay.
But these are the practically when you are giving the drug, these things are important. Okay.
Yes, ma'am.
So in this case, after medical management, what
So
other?
if medical management fails to bring the pressures to the target range, then we can go for surgical management. So surgical options available with us
Before
are
surgery, anything you want to do? Or
we
directly
can
go
also go
surgery?
for a laser trabeculoplasty, like argon laser or selective laser trabeculoplasty. That can be done for, and that is also done only for open angle glaucomas. And then lastly, we can shift to filtering surgeries like trabeculectomy, or if we want not a very low target IOP, then we can go for minimally invasive glaucoma surgeries. And then we have the glaucoma drainage devices and the tubes that will help to bring down the pressures.
So they will ask you in exam what is the ALT and SLT differences. Okay, that what are the advantages and disadvantages of each procedure and how you do. Which lasers are used? ALT and DLT, SLT.
Ma'am, double frequency Q switched NDAC laser of 532 nanometers.
Used in
What is-
SLT. Okay.
Yes.
So those thing differences they will ask. Okay. So coming to then finally trabeculectomy.
Yes,
With
ma'am.
with antimetabolites you use or
With antimetabolites like mitomycin C.
all cases you use?
Ma'am, it is not necessary, but in our institute we use it for all the cases because we want to avoid any other failure of the trabeculus by the trabeculectomy by increase in the inflammation and healing of the.
What are the complications of antimitotic agents?
Ma'am, it can lead to scleral thinning and increased inflammation. I mean,
when thinning is there, what can happen?
scleral thinning,
Blebitis.
scleral perforation, scleral melt.
Blebitis.
And that can eventually lead to blebitis, endophthalmitis.
Those things are, when you use, you should be very cautious and when you're using mitomycin C. Okay.
Yes.
And also those also high risk cases we use. High risk cases we use. Which all are the high risk cases?
Ma'am, again, one-eyed cases or with advanced disc damage where it is very important for the trabeculectomy to work. Or in cases of post-trauma or any secondary glaucomas where again the inflammatory response is very high. So there are higher chances of vascularization and fibrosis of the bleb, or in pediatric cases.
If there is failure, when you can, what are the characteristics of bleb? Filtering
So,
bleb. What are the
bleb,
facts of filtering bleb?
filtering bleb should help in bringing down the IOP. So the first way to check that the bleb is functional is to know if the IOP is fine. And the bleb has to be diffuse, not localized, and it should be raised and not like raised and not a flat bleb, and it should have microcysts on it and mild to moderate amount of vascularity present on it.
when this thing trabeculectomy, what are the causes for failure of trabeculectomy?
So, ma'am, increased inflammation. So basically, the healing process, increased inflammation, can most likely lead to a failure of trabeculectomy. Again, in pediatric cases or status post trauma or uveitic glaucomas, inflammatory glaucomas. And if the ostium is quite small, then it can get blocked again. Or if there are probably if there is a very tight suture, then there can be underfiltration and IOP control will not be achieved.
Here
Or if
we
there is
have to divide it into immediate post-op and late post-op.
late post.
And then your this thing will be very easy to tell. Immediate, what are the immediate causes and what are the late causes. That time it will be very easy for you to write also and to remember answer also. Okay. Then when you go for even when failed this is there, which other modalities you prefer?
Sorry, ma'am.
Like failed trab is there. What you will do? First time you have done, it is failed trabeculectomy. Then what
so ma'am, in a case of a failed trab, we can again go for a repeat trabeculectomy as well. If there is conjunctiva we have which is healthy enough to hold another bleb. Otherwise, we can go for glaucoma drainage devices. So something like the valved or non-valved glaucoma drainage devices. So like the commonly used valved glaucoma drainage devices, the Emmet glaucoma valve, or the non-valved ones like the Orolab drainage device implant, or the bare walls Maltino, all those implants. So they can be used to help tide over the high IOP.
Okay.
Shruti, you heard of needling of the bleb?
Yes, ma'am. So when the IOP, we feel that the trab is failing, and there could be a lot of fibrosis and like a membrane formation. So we can go with a needle, we can go and help clear all the fibrosis. And the ideal endpoint is when you can pass it through the ostium as well, but that is probably not done every time. But this is a way to salvage all the by removing all the fibrosis. We try to salvage the bleb before we go for another trabeculectomy.
Existing bleb can be revived.
Apart from needling, anything you can use, anything you can do? Any injections you give?
Yes, ma'am. We can give injections of mitomycin C or 5-fluorouracil around the bleb. So this can be done in the initial phase. About around 3 to 5 injections, around about 5 to 7 days apart, can be given to try to salvage the bleb. So that can be done in an OPD basis, and can help to bring down the height.
Anupama?
Yeah, I think we can shift to the next, or
yeah. Shruti, well done. Very nice
Thank you,
presentation.
ma'am.
Yeah, only
Thank you,
few
ma'am.
this thing you have to note whatever
Yes,
is
I'll
done,
read
just
up,
go
ma'am.
through those
Yes.
things. Okay, these are
Yes,
the
ma'am.
questions
Sure.
are, and your long
Yes.
case you should do very well. Then because
Yes, ma'am.
exam you will have around 7 cases. So first long case if you do well, and that impression will carry throughout your this thing. Okay, so
Yes.
first impression is the best impression. So do your long case properly, then you can go through exam easily. Okay.
Sure. Thank you, ma'am.
Well done.
Thank you.
Well
all
done.
the
Prepare
best.
well and all the best.
Thank you so
All
much.
the best.
Thank you, Dr. Stuti, for that wonderful presentation, and thank you, Anupama ma'am, Jayashri ma'am. I think I relearned glaucoma, so many basics of glaucoma with all these presentation. Right from the question that frequent change of presbyopic glasses to the bleb needling, I think it was a real good revision for us too. And now we have Dr. Gautami. Dr. Gautami, are you there? I am not. My Zoom has hanged in my laptop, so I think I won't be able to unmute you or re-let you. So please, Dr. Gautami, please unmute yourself. Are you there? Dr. Gautami, if you are not there, I think you just messaged me that you are there. Can you unmute yourself, Dr. Gautami? And re-log in, wait.
Yes.
Navneet or Amit? Dr. Gautami, you are there? Are you able to hear me?
Hello, Dr. Gautami.
In progress.
Wait.
Ma'am, she is not connected
Yes.
properly. She can leave and then she can join back.
Gautami? Can you just log out and re-log in?
Hello.
Yeah,
Can I-
Dr. Gautami,
Hello.
you're audible. Please start now your conversation.
Hello.
Yes, Gautami, can you switch on your video so that Anupama ma'am and Jayashree ma'am would be able to see you?
Hello.
Yeah, you are audible, Gautami.
I request the
Good evening,
postgraduates
ma'am.
who are
Can I
presenting,
start the
please log in
presentation
through
now?
your laptops. Don't use mobile as far as possible. The postgraduates, please. Yes, Gautami, we are able to see you. So are you able to hear us?
Voice is breaking now.
Are you able to hear at least Anupama ma'am, Jayashree ma'am, if my
Can I
voice is
start the
clear?
presentation?
Yeah, you are audible.
Yeah, you can start. You are audible actually.
Gautami, share the presentation and you can start with your presentation.
Hello.
You can start. Yeah, you're visible, audible. Please start, Dr. Gautami.
Good evening, ma'am.
Good evening.
I'll start my presentation, ma'am. A 55-year-old male patient, farmer by occupation, from Mandya, presented with the chief complaints of pain, redness, diminution of vision, watering in the right eye since 1 month. Patient was apparently normal 1 month ago. Later, he had an injury which he had developed following complaints, that is, diminished pain in the right eye since 1 month, which is insidious in onset, gradually progressive. It's a dull aching pain, and it is increasing on exposure to the bright light, and it is to used to relieve with the medication, and there is no diurnal variation. It is associated with the redness, watering, and the mucoid discharge in the right eye since 1 month, both for the far as well as the naturally progressive in nature, and there is no diurnal variation. And there is a history of topical eye drops usage and details of which patient didn't give. And there is no history of itching, colored halos, no history of headache, nausea, vomiting. There is no history of any skin lesions or pain over the surrounding the eye. There is no history of contact lens usage. There is no history of swimming or other contamination, contaminated water. This and there is no history of local quack treatment, and there is no history of spectacle usage prior, and there is no similar complaints in the past, either in the same eye or in the other eye. In the past history, patient is not a known case of diabetes mellitus, hypertension, asthma, tuberculosis. Patient is not on any chronic medication, and there is no history of ocular surgeries prior. There is no significant family history. Personal history, he had mixed diet, appetite is normal, sleep is disturbed, bowel and bladder was normal. He doesn't have any other habits of smoking or alcohol. General physical examination, patient is moderately built and nourished and well oriented to time and place, and the vitals were within normal limits. General physical examinations were normal limits. Coming to the ocular examination, patient had a normal head posture with a symmetrical face. Forehead is normal. Eyebrows at a normal level, at the same level, and the orbital margins are intact and non-tender. And coming to the right eye examination, visual acuity. In the right eye, unaided visual acuity, distant vision is hand movement positive, and projection of rays is accurate in all quadrants. There is no improvement with the pinhole, and near vision is less than in 36, and color vision could not be assessed. On dilated refraction, there was no glow and there was no improvement. And the best corrected vision in this eye is hand movements positive. And on external examination, eyeball was in normal position, and the movements, both the ductions and the versions were full range in this eye. And coming to the eyelid, it was there was a mechanical
Can I
process
stop you?
covering
Gautami, please.
Yes, ma'am.
History, you just briefly you tell history and the provisional. What are the differential diagnoses?
A 55-year-old male patient, ma'am, with farmer by occupation, had a history of diminution of vision, pain, redness, watering in his right eye. And this was painful. The diminution of vision was painful and it is progressive in nature. And he had a redness also, which is unilateral, non-radiating, and which is more with the more on exposure to the light. Provisionally, maybe the corneal ulcer or can be
trauma was there. History of trauma was there.
Yes, ma'am. With history of trauma with sugar cane stick.
Okay.
And topical drops usage, details of which she doesn't know.
Okay. Any other things you want to quit? Only corneal because it's given. Any other differential diagnosis for painful red eye?
Irido's can be an acute anterior uveitis or any angle closure attacks.
Yeah. So just you have to keep those things also in mind because it is given. Okay. Otherwise, those things also you should keep in mind for painful acute red eye. What are the causes? Okay. Go ahead with the examination.
Right eye examination, vision examination, the right eye, hand movement positive, no pinhole improvement.
You already told that, yeah.
Yes. In the external examination, eyelids, there was a mechanical ptosis covering about 4 mm of the cornea. And the skin, there is an edema in the skin. Movements were normal. There is no lag of thalamus. Bell's phenomena was normal. Palpebral aperture, it is 6 mm vertically and 30 mm horizontally. And lacrimal apparatus, normal puncta, it is well opposed to the globe. And lacrimal sac area was normal. Rho plus was negative in that. Conjunctiva, there was diffuse conjunctival congestion as well as circumciliary congestion. Sclera was normal. Cornea was normal in size shape. There was a lesion noted on the surface. The sheen and the transparency was lost. And there was a superficial vascularization noted from 8 o'clock to 9 o'clock position. Corneal sensations were intact. And coming to the lesion examination by diffuse illumination, slit lamp examination of the right eye, there was a yellowish white central and the paracentral lesion having an irregular corneal infiltration about 4 into 5 mm vertical and horizontally. It is a dry looking with an irregular feathery elevated margins and hello.
Yeah, you can proceed.
Right eye diffuse illumination slit lamp examination shows there is an yellowish white central paracentral lesion measuring 4 into 5 mm in dimension, vertical, horizontal. It is a dry looking with an elevated margin, irregular feathery edges, and there is a sloping edge with a central clearance. Surrounding cornea was edematous, and there was descending membrane folds were there. There was no pigmentation. Hypopyon of 2.5 mm vertical height and extending from 5 to 7 clock hertz, and there was superficial vascularization from 8 to 9 clock hertz. On focal examination with a slit beam illumination, there was an ulcer which is infiltrating more than 50% of the stroma with a thinning of the cornea is noted. There was stromal edema and descending membrane folds were there. There was keratic precipitates on the endothelium. On fluorescent staining with hello.
Yeah, you can.
Hello.
Yeah, continue, Dr. Gautami.
Focal examination with the slit beam illumination shows an ulcer more than 50% of stromal infiltration, and the corneal edema and descent membrane. On fluorescent staining under cobalt blue filter, it showed a central epithelial defect of 3 into 4 mm vertically and horizontally. Seedl's test was negative and there was no active leak. Anterior 2.5 mm height, extending from 5 to 7 o'clock. Iris peripheral details were seen, it was normal. The pupil was 4 mm, it was not reacting for both direct as well as consensual light reflex. Lens appeared cataractous. Intraocular pressure could not be assessed. On fundus examination, there was a hazy media and the posterior details could not be made out. Examination of the left eye. Left eye visual acuity was 6/60. Ma'am, am I audible?
Yeah, you are audible.
Left eye examination. Vision, uncorrected visual acuity in the left eye was 6/60 and which was improving with the pinhole to 6/36. Near vision was N24, color vision was normal. Dilated refraction at 1 meter distance under tropicamide shows a neutralization with a -2 diopter vertically, -3 diopter horizontally. Patient accepts -2.5 diopter sphere, -0.75 diopter cylinder at 90 degree with an improvement to 624 and a near add of 2.25 diopter giving left eye external examination. Eyelids were at normal position. The skin over the lid movements and the margins were normal. It had a
Anything abnormal,
normal
you let
wells.
us know.
Any positive
In the
findings you just mentioned?
Only positive findings you tell.
Left eye external examination was normal and only senile immature cataract, nuclear sclerosis grade 2 to 3 with posterior subcapsular cataract was noted. And there was a capping of meibomian glands in the lid margin was noted. Rest of the examination and the fundus, both anterior and the posterior segment examination was normal.
Clinically, what do you think this corneal ulcer is? Dr. Gautami?
Ma'am, her internet is unstable. It's not so stable.
Okay.
I think she has to either switch off her camera so that her internet you can hear her properly.
Yeah, even if she's audible, it's okay.
Ma'am, Dr. Gautami, can you switch off your camera and speak because your internet is quite unstable? Dr. Gautami?
Unable to hear you.
It's okay if you're audible also, it's fine with us.
I'm unable to hear your voice clearly.
You are not able to hear?
Ma'am, you are clear, ma'am. You are quite audible, and Dr. Jayashree also is quite audible. Only thing is, Dr. Gautami's internet is not stable. That is why she is not able to hear you.
Mm-hmm.
Dr. Gautami, could you please switch off your video and speak with the examiners?
Yes. Yes.
Go ahead, ma'am.
Yeah, Dr. Gautami, can you tell your provisional diagnosis now?
My provisional diagnosis in the right eye, it is a moderate grade corneal ulcer, query of fungal etiology in an active ulceration phase with an immature cataract. In the left eye, it is senile immature cataract, nuclear sclerosis grade 1 to 2 with a posterior subcapsular cataract.
Okay, so first of all, we need to know why you thought of infective etiology. So how do you differentiate an infective ulcer from a non-infective etiology ulcer?
Based on his complaints, the symptoms, that is a pain and pain, redness, watering, and based on my examination, which is affecting the vision, and there is an infiltration surrounding, and there is a circumcorneal congestion with the exudates in.
Yes, so it is main is the symptoms and the acute signs in the form of circumciliary congestion Okay. So that is one thing. The other thing is, you said it is probably of fungal etiology. So what makes you think this is probably fungal?
Patient is farmer by occupation, and he also gives a positive history of trauma with the vegetative matter, sugarcane stick, and he's telling he has used topical medication details which is not available. Commonly, which is prescribed over the counter are steroids, so that can aggravate the fungal thing.
That is based on the history. One is the chronicity. He has come after how many days now? Almost a month?
1 month later, based on my history.
Yeah.
Based
So,
on the symptoms, though he had many symptoms and he had presented over a long time, and here the symptoms are more like less compared to the signs that I have. And here, based on my examination also, the ulcer, it looks dry, feathery margin with the uh, infiltration, which is more. Though the ulcer size is more, the symptoms, it is not disturbing the patient as much as it should in the other cases.
So one is it's a large ulcer. He has presented late, dry appearance, feathery margins. Hello? What are other signs of fungal corneal ulcer apart from what you've already told? Dr. Gautami?
She's not able to hear, I think.
I think.
I'm unable to hear.
Dr. Gautami?
Gautami, are you able
I can
to
see
hear
her name
us?
on the.
She's there, ma'am, but I think her internet connection is so weak that she's not able to.
Ma'am.
Yeah, we can hear you. Tell me.
What are the other signs of fungal corneal ulcer?
Would it be better if she
Participants also
joins through
can
mobile?
answer. Other participants, anybody is there?
Stuti and Tejas, you can just unmute yourself and answer. I think corneal ulcer is the most basic case presentation which you all are supposed to know right from first year. So exam going, all of you, 100% you're supposed to know it. You can just unmute yourself. Stuti bar Tejas. Meanwhile, Gautami can re-log in once again. Tejas?
Yes, ma'am.
Yes. So ma'am wants to know what are the other signs of fungal corneal ulcer.
Ma'am, apart from the mentioned signs where the margins are irregular, feathery, and dry looking, and the ulcer are large, the size is bigger than what the symptoms are showing.
There can be
There
satellite
can be
lesions also.
hypopion, here. Hypopion sometimes can be seen, which is usually a sterile hypopion.
What else? How else the hypopion is different from bacterial hypopion? Apart from it being sterile?
It's also a migratory, like.
No. What are the other characteristic features of a hypopion in a fungal corneal ulcer? So it has more fibrin content.
Yes, it was thick. Hello. There was thick hypopion, immobile.
It's not very mobile because of the higher fibrin content.
And the convex,
and it has a irregular
configurity.
Convex appearance. Configuration will be.
And also you told sterile. Sometimes fungal elements can be found.
Elements can be.
Yeah, it will not be sterile sometimes. Because deeper penetration can occur. So it will not be always sterile in fungal ulcer.
Yes, ma'am, I can hear you.
Yeah, other signs apart from these, apart from satellite lesions, what else? Can you get any ring?
Yes, ma'am. Immune ring can be
Yes, ma'am,
seen
there
wherever
can be
there's an
ring
interaction
in
between the immune body's
Yes.
immunity and the fungal elements around that ulcer. There can be a persist ring.
Which other
So this
condition you can
immune
see the
ring,
ring?
this immune ring
Even in
is actually
acanthamoebic keratitis
non-specific.
also it is seen.
Yes. We can even sometimes see endothelial plaque. Okay.
Yes.
Endothelial plaque and thick abscess. Corneal abscess also can be there in long-standing cases. Corneal abscess is also many times fungal etiology. You told this patient is having a uveitis also. KPs and all were there, you told. Hypopion is there. What is the reason?
This has a deeper penetration also, ma'am. As the fungi can penetrate deeper, it can elicit the iritis as well.
Okay.
And anterior uveitis picture is same in this case.
Not only the organism, but also sometimes toxins. So toxins also can induce uveitis, okay?
So before
the
we
other-
proceed further, one
Differential diagnosis means other ulcers which look like fungal.
Even the acanthamoebic keratitis,
Yes.
pythium-induced pythium keratitis.
Okay. What are the features of acanthamoeba keratitis?
They'll have a peripheral ring-like ulcer will be present with radial keratoneuritis will be present,
Okay.
and the pain will be more compared to that of the signs, and they will have a ring abscess in the later stage, and immune infiltration ring will be present around the ulcer.
What are the risk factors for corneal ulcer?
Can be a local causes like the dry eye or lid related when they have a trichiasis or entropion, or when the diacrocystitis can be there. Systemic causes like diabetic patient, immunocompromised individual, anemic, and one who is on chronic medications like in the RBD positive patients.
Okay. So even long term of steroids and also long term of antibiotics also. Why?
Yes.
You know?
Because the local flora will be
Yeah.
affected with the long-term use of antibiotics.
Okay. You know which are the normal commensals? Normal conjunctival flora. Which organisms are there? Normal conjunctival flora. Gautami? Can you name normal conjunctival flora?
Tejas.
Yes, ma'am. Normal conjunctival
Yes,
flora.
normal flora of conjunctiva, ma'am is asking. Till Gautami logs in back. Can you please name the normal conjunctival flora?
Usually Haemophilus like Haemophilus parainfluenzae or Cornybacteria. I'm not very sure, ma'am.
Are you Google searching?
No, these all are
He's telling
exam
no,
questions.
conditions
I
which
want you to
penetrate
prepare.
intact
I
cornea.
want you people to prepare for
Neisseria,
this.
Neisseria gonorrhea, H. influenza.
No. Ma'am is asking normal flora. Normally,
I'm not
Neisseria
sure,
gonorrhea
ma'am.
will not be
No,
present
ma'am.
in our eyes,
Yes.
They are telling bacteria
which
which
can
will
penetrate the
intact.
intact epithelium. Don't
Intact.
get confused. Ma'am is
Yes, ma'am.
asking normal conjunctival flora, which is there normally in our eye.
So that is important when you use long term of antibiotics, steroids and all, the flora is altered and they can, normal flora also can cause an ulcer. So you should
And
read about those
Staphylococcus
things.
species, Staphylococcus aureus, Staphylococcus epidermidis.
Yes. So how do you proceed when you see a corneal ulcer now?
First thing we have, like before starting any topical medication, the scraping has to be done and the sample
Now
has to
your
be
patient has come after 1 month with all multiple drugs, I think.
Yes, ma'am.
So what you will do?
I'll scrape this cornea, the base and the margins, and I'll do the KOH mounting
You
to
want to
know whether it
withhold
is found.
antibiotic, whatever drops they are putting, you want to withhold for some time
Yes,
before
ma'am.
scraping.
Yes, ma'am.
That is important. You have to withhold and then do the scraping after 12 or 24 hours. Okay. What you will do? Which scraping you do?
Scrape under topical anesthesia, scraping using a 15 number blade or the 26 gauge needle from the margins of the ulcer as well as from the base of the ulcer. That scraping, I want to do KOH mount in this case to confirm whether it is fungal etiology or not. And also I want to send for microbiological investigation, both stains as well as culture and sensitivity.
Which other stain you would like to do apart from 10% KOH?
Gram stain if it is bacterial.
Yeah, many times the infection will be mixed also, so you have to keep that in mind. You must send for grams also.
Yes.
So when you are scraping, which one you will mount first, the staining or the culture?
First, I'll go for the culture part and then the remaining thing I'll.
Yeah, it's always first you have to put in the culture media. So minimum of 2 culture media you have to use. So which one you'll use?
For the bacteria, both blood agar as well as chocolate agar, and if for
We
the
won't be knowing whether it is bacteria. So at this stage,
I
we
want to
don't know
send
what
for
the organism is.
blood agar and SDM.
Subroot.
Yeah. So one is SDA and the other one is blood agar. Fungus can grow in both actually. So you can use.
Any other
Yes.
staining? Which other staining you do? Gram staining, you told KOH. KOH is very important. Do you do routinely in your this thing? You are from which college? Gautami? You do yourself KOH preparation?
Gautami is from Minto, ma'am.
Minto. Oh.
Okay.
Whether they will do themselves or they will send. That is also important.
Dr. Gautami. She's again
Is on off.
on off.
Hello, I'm able to hear.
She's back.
Yeah.
Mm.
You do it yourself or you will send it to lab KOH preparation?
Lab mostly.
Yes, ma'am.
Go ahead. Other people, Tejas, Stuti is there. You can also answer. About which other stainings you can do apart from grams, KOH?
Lactophenol blue stain calcofluor we can do.
Yeah. Okay.
Calcofluor
Calcofluor
white.
for which?
Yeah.
White. Calcofluor white, which organisms you want to see?
The acanthamoebic cysts and all can be made out easily, and even the fungi also
Fungi,
morphology
yes.
can be made out easily.
What color you will see cyst and trophocyte? Which color you will see in calcofluor white?
I'm not so
How
sure.
it appears?
Not so sure.
Amoeba cyst and trophocyte. Okay, what is the role of scraping? One is for investigations. Any other?
And it reduces the bacterial load also,
Yes.
and it helps the antifungal to stuck onto the site of action. So the drug availability can be increased.
Better penetration of the drug.
Yes.
Most
Better.
of these antifungals, no, they are not soluble in aqueous media, no?
Yes.
Yes.
What
So
other
usually if we
investigation?
do
Other
Yeah.
investigation, microbiology. Apart from microbiological investigation, what other things you want to do? Ocular examination, ocular investigations. Ocular investigations.
You told, no, in examination something negative.
Oh,
Gautami?
can I get the question? 1 second. I couldn't hear. Sorry.
Other ocular investigations.
I want to do lacrimal frenching to confirm the patency of lacrimal apparatus, and also wants to do a gentle B scan to know the posterior segment because the fundus was not present.
If along with dacryocystitis, which organism is more common? With dacryocystitis, which ulcers are common? Which organism in case of dacryocystitis?
I think others can answer. I think again we have lost Dr. Gautami. Her net is gone.
Staphylococcus and coagulase negative cons.
Dacryocystitis is pneumococcal. Pneumococcal ulcers are common. Okay. What are the features of pneumococcal? What do you call pneumococcal ulcer? What are the features of pneumococcal corneal ulcer? What do you call pneumococcal corneal ulcer? Tejas? What are the features? There are specific features of pneumococcal corneal ulcer. Tejas, can you hear me? Stuti?
Yeah, yes, ma'am. I don't know, ma'am.
Okay. Just go through whatever we are asking. You just again you will go back and study. Okay.
Ma'am, the ulcer will have a serpentine,
Yes. Yes. It is called
and
as
it's a ulcus serpens.
yes, ulcus serpens or hypopion corneal ulcer. Corneal ulcer with hypopion is different, and
Usually
hypopion corneal ulcer is usually pneumococcal. Okay. How do you manage this case now? Treatment aspect. Stuti.
Ma'am, management will essentially be topical antifungal treatment along with, if required, oral antifungals like ketoconazole can be added. Before that, we have to get a liver function test checked for the patient because the drug is hepatotoxic. And along with that, for the pain, we will also give like a homemade cycloplegic eye drops to the patient, lubricating drops, and we can also give oral painkillers to the patient to deal with the pain as well as the
Which
inflammation and edema.
antifungal eye drops are available?
Natamycin, we can give Natamet, and along with that, if later on, if required, voriconazole can be 0.05.
5% natamycin.
0.5.
5%.
5%.
5%
Sorry,
natamycin.
5%. Sorry.
One drawback with natamycin. What is the major drawback with natamycin eye drops?
It's a particulate formula, so
Main is penetration. Poor penetration. So you need to repeatedly scrape for better penetration. Okay. How long you want to give this antifungal eye drops?
4 to
we
6
continue
weeks
with
it has
this?
to be given.
Sorry?
Continue.
For how long you'll give and how
Till
you'll
we
monitor patient?
till we see signs of healing within the ulcer, like if there's a hypopion, then there's a decrease in the size of the hypopion. There is a decrease in the size of the infiltrate. The margins of the ulcer are healing. Then
So usually
so
these ulcers take how long to heal? Usually fungal ulcers take how long to heal?
about 3 to 4 weeks. And
Yeah, so usually
at
they are,
least for that, at least for that much time, we'll give the treatment, because even later on we'll continue.
yes.
What are the sequelae of corneal ulcer? Once corneal ulcer is there, what are the sequelae? Sequelae of corneal ulcer. What all things can happen when corneal ulcer is there? What
Can be
sequelae?
a corneal, if it heals appropriately, then it can lead to a corneal opacity, like
Yes.
a leukomatous macular or leukomatous opacity. And otherwise, if it does not respond to the treatment, it can lead to corneal thinning or corneal perforation, corneal melts. And in extreme cases, it can lead to endophthalmitis as well.
What are the things? So many things are there. Sequelae. If perforation occurs, how you will manage?
So, for perforation, it depends
Depending
on the
on the
size
size
of
of
the
the
perforation.
Yes.
If it's
If it's less than 2 millimeters, then we can go for just cyanoacrylate glue with a bandage
Glue.
contact lens.
anything between 2 to 4 centimeters, depending on
Millimeters.
millimeters, you can treat it with a Venus patch graft, or you can even use amniotic membrane grafting can be done to close the seal of the wound.
What is corneal fistula? Corneal fistula. When it occurs? Corneal fistula. When it occurs?
When I am not sure, ma'am, but I think when a thinned out cornea or
Where should the site of thinning
the
be to cause a corneal fistula? Can it occur anywhere in any clock hour? Central, paracentral, peripheral, or any clock hour? Which is more likely to go for corneal fistula?
It's a central.
Central.
Peripheral, what happens? Iris will go and plug. Centrally, so central, usually central ulcer, the anterior lens will come front, it will close. Again, when there is a precipitating factors, it will open up. Even normal intraocular pressure, it cannot withstand. So repeated, this will cause a corneal fistula. What else can occur? If cornea is sloughed off. If cornea is sloughed off, what can occur? What is pseudocornea and what is false cornea? That difference you should know. What is false cornea and what is pseudocornea? Do you know? Tejas? What is false cornea and what is pseudocornea?
and the condensation of the exudates, when they condense and they
Yes.
form a membrane over the perforated cornea, it is pseudocornea. False cornea.
That's a slight difference is there. False and pseudo. False cornea is just exudates. It will cover the open area. That is the false cornea. Over that, there will be epithelialization, conjunctival epithelialization. That will form a pseudocornea. Okay. What other sequelae can be after perforation? After perforation, what are the things can happen? Sequelae.
If the iris goes and plugs over there, I mean, there can be an adherent glaucoma or there can be a descemetocele.
Yes. Then, what are other things? Lens can come out. It can occur if precipitating factors are there. If precipitating cough, any strenuous exercise, anything is there associated with that, expulsion can also occur. Then, what other things? If infection can spread inside, what it will cause?
Endophthalmitis,
Endophthalmitis. Also, secondary glaucoma also you should never forget. Okay. Corneal ulcer can also cause secondary glaucoma. So these all are the sequelae of the corneal ulcer. So one is
How do you
go ahead.
How do you treat a impending corneal ulcer? Suppose you have seen a descemetocele, it is not yet perforated. How will you manage that?
First thing, we should advise the patient not to do any pressurized activities like cuffing, straining, and all. The second, we can place a glue with the BCL.
Yes. Then?
And we can do Tinon's patch grafting or conjunctival. If it is in the periphery, you can patch with the conjunctival.
Yeah. Do you want to give acetazolamide?
Yes, ma'am. To reduce the intraocular pressure.
Yes.
Even patching also can be done. If BCL and all is not available, take a risk factor management, give Dimox, and patching itself also will protect. Okay, that was if BCL is not available, then you can do other things. Anupama?
I think penetrating keratoplasty and all will be too much to ask here. It's enough if they tell that. We'll not discuss that here.
Yeah.
I think antifungal oral, they just need to know the different types which can be given here.
And what are the indication of oral therapy, systemic therapy in corneal?
Whenever it is a deep corneal ulcer with a more than 50% stromal involvement, or if there is any sclera involvement is there, if the periphery near the limbus involvement.
Yes. Even
and it is not.
We are perforations, corneal perforations. One more thing I wanted to ask you in management, if this all scraping everything, if it comes negative, what else you can do? You're staining, whatever you do, or if corneal abscess is there, or deep plaque is there, deep stromal infiltration, that time how you will proceed? If deep stromal infiltration is there, scraping will not help.
Clinically, it is improving. We can continue the same antifungals, but if it is not still worsening, we can take a second scraping of that.
No, if it is deep, I'm asking. If it is deep, stromal or endothelial block is there.
Suture can be used, ma'am, to pass through the like you have to pass through the depth wherever the thing is, and the exudates or whatever the material comes with your suture can be used to.
Yes. Then biopsy, can we do corneal biopsy?
Yes.
Yes.
Partial thickness lamina.
Can do that also. Any other things? AC tap you can do?
Yes.
If the hypopion is suspected.
AC tap. Okay. Role of confocal laser in ulcers. Role of confocal laser. It will help in detecting the organisms.
Yes, some cysts and all in vivo, we can localize the cysts which are present.
Okay. So that's what. If you don't get all these things, you have to, apart from scraping, these things also you have to go in some cases. Okay. PCR with aqueous tap to know the organisms. Sometimes fungal ulcer. Which other ulcer will look like fungal?
Acanthamoeba.
Acanthamoeba. Anything else?
Pythium.
Pythium.
Microsporidiasis. That also, it's difficult to get organisms. So that time these things will help you out. Okay. Okay. So then again, you have to read about the organisms, classification of fungi, antifungal drugs, complications, systemic, this thing, all those things you should read. Okay.
Even classification of fungi also. I think they should know the
That's what
names of the
classification.
different types. Yes.
Sometimes corneal ulcer, you can see the pigmentation. So
Pigmented fungi.
Okay. So,
Alternaria and
yeah,
carbohydrate.
so those things also important. Pigmented fungi. Okay, then we'll stop here. Gautami,
I missed half of it.
She's
you
smiling
should have
now.
taken
Finally,
care
we
of
can
your
see her.
Thank you, Gautami. Thank you, ma'am. I think when I presented in I2I, when I was a postgraduate appearing for exam, I had one eye corneal ulcer and the other eye was thysis bulbi due to cirrhosis. Believe me, I was very happy, and the person who took my Viva OC in I2I was TK Ramesh sir. He didn't ask me a single question about corneal ulcer because he said, I'm assuming every PG knows everything about corneal ulcer, and he totally went into trauma, sidrosis bulbi, charcosis bulbi, all those things. So I think the thing is that here, ma'am and both the ma'ams have been very generous with you and they have discussed only
yeah.
corneal ulcer, but that doesn't happen so in the exam. It can go in any way in your examination. So hope all of you are well prepared for the second eye, which doesn't have any complication also. It can be just a cataract, which can be discussed in the exam, taking the other eye also. So be ready with all type of question which can come in your Viva OC. So all the best, Gautami, Stuti. Now,
Thank you, ma'am.
and thank you, Jayashri ma'am, Anupama ma'am. I think we had a very good anterior segment case presentation discussion. The best part was I was active on YouTube and there was continuous answers which were coming from the other postgraduates. They have been answering continuously. The answers which were not given by you three here were being answered there in the YouTube and I was actually replying them over there. So all the postgraduates have been very active here. But it's not always the anterior segment. The posterior segment takes up some part of your case presentation marks too. And today we have with us Dr. Apurva to discuss with us a case of retinitis pigmentosa. Dr. Tejas would be presenting to us about the case of RP. I hope Tejas, your internet is good and you don't just disconnect off in the between. So over to you, Dr. Tejas and Dr. Apurva for continuation with an RP case. Thank you, Jayashri ma'am. Thank you, Anupama ma'am. It was wonderful having you with us here. It was a learning for us also for both cornea, glaucoma, doing only pediatric. I had forgotten those two parts. And thank you for refreshing our school, college memories and refreshing our basics also. Thanks a lot, ma'am.
Thank you,
Eternally
Dr.
grateful.
Dipti. Thank you. It was a pleasure really attending the
Thank
session.
you, ma'am.
Yeah,
Thank
thank you.
Bye.
Even we learned so many things from
So-
you. And
Yeah.
thank you, Dipti, and convey our thanks to KP
Thank
sir
you, ma'am.
also.
Yes, ma'am. Thank you. Thanks
Thank
a
you
lot,
so
ma'am.
much.
So now I hand it over to
Bye.
Tejas and Dr. Apurva to continue with the posterior segment, please.
ಏನು?
Dr. Tejas, start presenting, please.
Yes, ma'am. Should I screen share or just start presenting, ma'am? Okay.
Ma'am, should he share the screen? Would that be better?
I'll share during the fundus pictures.
No, you can share now also. For the
Okay.
benefit of everybody. Everybody can see the history instead of just hearing it.
Yes, start your PPT. Share your PPT, Tejas.
Is it now
Yeah,
audible and
please go ahead.
visible, the screen?
Yeah,
I'll just
go
turn
ahead.
off my camera, ma'am, because again the
Yeah,
internet will fluctuate.
yeah.
So, uh, we are presented with a 45-year-old lady who was a homemaker by occupation. She complained of diminution of vision for distance as well as near in the dark since 4 years. The vision in the left eye has worsened more in the last year compared to the right eye. On further questioning, she said she has been experiencing this diminution of vision in the dark, and it was insidious in onset and gradually progressive. She also complains of a decrease in near vision, especially in the left eye, for the past 1 year. So, based on this, a negative history, which a part of that was taken retrospectively, and she said that it was not associated with pain, redness, watering, floaters, or flashes. There was no distortion of images or discharge. There was no history of use of any thick glasses, though no common known chronic systemic illness associated with deafness, cardiac problems, or any skin issues were found out. There was no history suggestive of mental retardation, and no history of systemic and ocular medications for any long-term use was found.
Tejas, may I interrupt
Yes,
here?
ma'am.
Mm, Do you think there can be anything which can be a treatment after which patient can have symptoms of defective vision in less than bright light or dark?
Ma'am,
Any
some ocular
treatment
talks
that,
like TB treatment.
can you hear me out? Yeah. So,
Yes,
is there any treatment that we give as retina specialists, to be more specific, which can cause
okay.
night vision problems? Anybody?
Pan-retinal
Um,
photocoagulation, ma'am.
Very
PRP.
yes.
Yeah.
PRP can cause.
If extensive
Why?
PRP is done.
Why, Gautami? Why does that cause night vision problems?
Because of the peripheral retina is being lasered out. So vision in the
So
scotopic
most
light
of
will be
the
affected.
rods are gone because of photoablation. That is why they'll have night vision problems. So one negative history, if you can include, is no history of retinal lasers. Maybe that can
Yes.
also be a negative history, because anyway, this is all retrospectively you have taken, right?
Yes.
That's why. Any other sign in the eye which can be noticed since childhood?
Vitamin A
The
deficiencies.
white ref
No, they will not say history of vitamin A deficiency. No, what I'm saying is a sign, an
the
White or
obvious.
white
spot.
reflect
Hmm?
hemolytic white reflexive since childhood if there's
Why would you ask that?
um,
So, involuntary eye movements is something I would write in this, because nystagmus can also be part of a lot of dystrophies.
mm, yes, ma'am.
Involuntary eye movements. Okay, yeah.
The personal history was that she was conceived out of a non-consanguineous marriage. She is now married with a 12-year-old son. There are no any addictions. Menstrual history is normal. Sleep, appetite, bowel, bladder movements are normal. On family history, we can see that uh, her father was affected with similar.
Can you go back to the negative history? Okay. Systemic medications that can cause night vision problems?
Any TB treatment which was taken, or if there were
Why
any,
treatment?
it can cause maculopathies. It is
Night
not
vision
specific to
problems.
night. It is not specific to night vision problems, but the
So
overall decreased
predominant
vision they
history
might feel.
the predominant history we can assume in this patient is, one is night vision, that is difficulty
Dark adaptation.
in low illumination. difficulty in the dark, and one more is near vision problems, correct?
Yes, ma'am.
Okay. So in which medications will cause difficulty in night vision? Stuti, Gautami?
Ma'am, chloroquine, phenothiazine.
Okay. Atypical
Any
antipsychotics also, chlorpromazine.
clofazimine, if it.
Okay. Next. Okay. Where were we? Yes. Personal history. Family history. Okay.
In family history, her father and brother complained of similar issues, although
Okay.
there was no such history coming from the husband's family side, and her son is also not having any such complaints.
So when you look at this pedigree chart, what do you think is the mode of inheritance?
We can suspect that it is a dominant trait which is being, but since it's only two generations which we can see are affected, usually we need at least three generations which consecutively which are affected to see that it is a autosomal dominant trait.
Hmm.
So here we can just suspect that it is a autosomal dominant trait which is being affected in this family.
So how will you ask for previous generation affected or not? This lady is
Uh,
your proband, no? So how will you ask?
we'll ask if there were similar in if her father also had
So father
frequent
is
falls
one
at night.
generation.
Her father is in
Hmm.
anybody in her family used to have difficulty to see late at night, or they used to have frequent falls, or they have had frequent falls at in the evening or when it is dark, or things like that.
So previous generations, I'm asking. You went up to only the father, no?
Acha,
Is it possible to go further backwards?
uh,
So you can ask about grandparents. Did they go, were
yes,
they blind as you know them, as you knew
uh,
them? Or your paternal uncles, maternal uncles, maternal aunts, you can ask like that. So you should not just stop at the parents. Should always
yes,
go to their siblings and their parents also. So something like a event like this, like a night vision problem, is something that happens in families, and it becomes a kind of a social situation. Okay, so that family is kind of known. Why I'm talking about it, these are socio-economic impacts of these diseases, these
yes,
long-term diseases. So it is very, very possible to take 3 generation pedigree. Okay,
yes,
so it will be well known about which relatives in the family had similar problems. So it's not enough to go to the just the parents. You can go to grandparents, siblings of the parents also. They are very
yes,
vital clues. Okay, yeah. And you don't know if the son is not affected unless you have examined, because screening of the children and screening of the siblings is a uh,
yes,
separate exercise that we take. So until we have seen them, we don't know whether they are affected. Okay, anyway, so go on.
On systemic examination, all the vital signs were within normal limits. She was afebrile, no pallor, icterus, clubbing, sinuses, edema, or lymphadenopathy was seen, and no skin changes or any polydactyly was observed. All the other like CNS, cardiovascular, respiratory system, and per abdominal examinations were normal. Ocular examination was done in a normal head posture. There was facial asymmetry, and all the extraocular movements were full
Facial
and free.
symmetry. Facial symmetry.
The facial symmetry.
Okay. So, what do you think of this patient who has had night vision problems from only 4 years? Okay, why do you think this patient, the symptoms started in the 5th decade? She's 45, I think. So, why
45.
have the
Yes.
symptoms come at this age? So, what does that tell you about the inheritance? Does it give a clue about inheritance?
Yes, ma'am. Usually autosomal dominant inheritance, they are presented late in life, usually after third or
This is
fourth
not
decade,
late in life. This is
where
middle age. This is productive middle age only.
yes,
So autosomal dominant will
yes,
come as late as 6th to 7th decade or even later. Autosomal recessive will come from 2nd to 4th decade. X-linked recessive is the most severe and it comes in as early as infancy or first decade of life. Okay.
yes.
And okay. So why do you think this patient has deterioration of the near vision? What can happen? Okay, let's go
Ma'am,
ahead with the examination and then we'll.
um, I should first examination or the answer?
We'll go with the examination first.
Yes. So on examination, on the right eye, the best corrected visual acuity was 6/9 with minus 2.5 diopter cylindrical at 100 degrees. And near vision was an 8 with plus 1.75. The cornea, anterior chamber, and pupil and lens pupil were normal, whereas lens showed some cortical cataract with minimal posterior subcapsular cataract. The intraocular pressure with Goldman applanation tonometry at 1 p.m. was around 14 millimeters of mercury. On left eye, the best corrected visual acuity was 6/36, and it was not improving with pinhole, whereas the near vision was N24 with no further improvement. Cornea, anterior chamber, and pupil were normal, and lens showed cortical cataract with minimal posterior subcapsular cataract. Intraocular pressure was 16 millimeters of mercury.
So I will interrupt you here. See, minimal PSC in a patient like this is very significant. We will see the fundus findings and then I'll come back to the PSC. Yeah, let's go forward. Let's go forward. Let's go forward.
Just the screen has hanged.
Okay.
On can the fundus picture, is the fundus picture visible?
Yes.
Uh, Posterior segment examination was done with 90D initially, and then with 20D and indirect ophthalmoscope. This is a optos picture of right eye, which shows waxy pallor of the disc, and the margins are sharp and well delineated. The parafoveal region seems to be normal, whereas the vessels are attenuated and the foveal reflex cannot be seen. The peripheral and mid-periphery and peripheral retina show multiple hyperpigmented areas, giving rise to a mottled appearance.
Okay. So there are some problems with the fundus diagram. So whenever you draw the disc, it has to be outlined in black. Can you hear me?
Yes, ma'am.
I'm sorry, I have. 1 second, please excuse me. 1 second. Yeah, sorry for that. Tell me. So whenever you draw the disc, it has to be outlined in black. That is the convention that we follow. And the first order vessels go up only to the arcades. And if you see the optos, it is helping you that they don't go all the way to what is the first circle? What is the first circle in the Amsler-Du Bois chart? What is it show? What does it signify? The first circle. Anybody? Quickly.
Equator,
Ma'am, the equator.
So do the first order vessels, when the vessels come out of the disc, do they go all the way to the equator and then branch?
no, ma'am. In the
No.
posterior
No,
pole.
ma'am, before that. At the
Yes.
posterior.
So nearly 2 disc diameters from the fovea, it starts branching. So this is a frequent mistake that is made by most residents, that they show the branching much beyond what is seen. So this is very important, that the first branching should be much closer than you have shown. Then what is the second circle?
Hello.
Ora serrata.
What is the
Ora.
second circle?
Ora serrata,
Ora.
ma'am.
Ora. So are the pigments going up to the ora? So this is a 200-degree fundus photograph, and it's very obvious that they're going to the periphery much more than the equator. You have drawn your bony spicules round the equator, that's it. So beyond that, there are a lot of pigmentary changes, bony spicules. Okay. So then coming to the fovea, the fovea should be in line with your 12 o'clock meridian. Okay.
Okay.
It is slightly off center. And you don't have to mark the ora because you have not indented. Usually ora is seen on indentation. And if there is any media haze because of the PSC especially, you have to show the haze with 3 striations with a green pencil.
Yes.
Okay. Then, okay, now can you describe the fundus?
This is a first picture of a left eye.
By convention,
This
we talk about right eye first. By convention.
right eye.
Yeah, go on. Yeah, tell me about the right eye. Yes.
So first picture of the right eye, the disc showing a pale waxy color. The margins are well delineated. The parafoveal area is appears to be normal. The FR is not appreciated, and
Why are you talking
there
about
is
all
a
the
greenish.
vessels you have not spoken about? So we usually describe the disc, the color, size, shape, margins. Then we talk about, since this is a case of like complete pallor, waxy disc pallor, we don't talk about the cup. We say the cup is not discernible because the waxy optic disc pallor. Then we go to the vessels, because they come first, because vessels come out of the disc. So we talk about AV ratio. What is the AV ratio?
AV ratio appears to be 1:3.
1:3. Okay. Okay. So you're saying that the arteries are attenuated and the veins are normal.
Veins are not
Okay.
relatively.
Okay. Then we come
There
to
is
the
a macula.
Then we come to the
So
macula. Posterior pole, we say macula. So what is there in the macula?
there is a shiny membrane suggestive of epiretinal membrane over the macula, and the mid-periphery and peripheral retina show multiple pigmented areas, giving it a mottled appearance.
Okay. You can say that there are multiple discrete pigmentary lesions as well as confluent pigmentary lesions. Confluent pigmentary lesions are more in the mid periphery, and they become more and more discrete as we approach the periphery. In addition, there are a few spicules within the arcades as well, near the macula, near the fovea. Okay. Then there is a central opacity. Can you see? So that would be
Medial.
very visible on distant direct ophthalmoscopy. Okay, these fundi on distant direct ophthalmoscopy also have a typical sheen. They are not the regular red glow. They have like a sheen which is different from the red glow that we see on distant direct ophthalmoscopy. Okay, so DDO in this case is important because there is a PSC, you said.
Yes, ma'am.
So that is why that central black thing is seen, no? Which is not allowing you to see the FR and the fovea, the parafoveal region. It's not seen because of the PSC. So that brings us to the important thing in RP, that is the correctable things in RP. It is not enough to say that there is no treatment. Okay, why I'm talking about this already in so early on in the examination is that even a minimal PSC is very significant for a patient with RP. So be very cautious when you say minimal PSC, because this patient most likely has tunnel vision, and this PSC is causing deterioration in the vision that is correctable. So if you remove this PSC, the patient will get back their tunnel vision at least. Okay, so there are very few things that you can treat in retinitis pigmentosa. One is refraction. A proper dilated retinoscopy has to be done to rule out myopia, hyperopia, astigmatism. Okay, these are correctable. You have to refractive correction for the patient is of paramount importance. Next, you have some patients will have keratoconus in retinitis pigmentosa. So that's why they'll have astigmatism. That is a triad of keratoconus, retinitis pigmentosa, and cataracts, zonular cataracts. That is a triad in one of the syndromes described by an Indian. Anyway, you can look it up. It's called Madan Mohan syndrome, named by a very astute physician in RP center very, very long ago. So they used to ask us about this in the exam. Keratoconus, zonular cataract, and retinitis pigmentosa. So these patients usually have high astigmatism, surprisingly sometimes. So you have to correct them properly. Then comes the cataract part. You said minimal PSC. Actually, you should not. Is there any grade for PSC? An objective grade?
Yes, ma'am. There is.
What is the grade?
4 grades where if only if you can see the breadcrumb-like appearance sticking to the posterior capsule, that is grade 1. If there is a fine demarcation line like a raised appearance, that is grade 2.
Can somebody tell it correctly? Stuti, Gautami. Are you there?
No, ma'am, I'm not sure exactly also.
Based on the quadrant of involvement, if less than 1/3 in the logs grading, we can grade.
So the grading is based on locks. So it has words like minimal and all don't have place in an objective grading, and especially in such a case. Okay, so that's why I'm saying just PSC you have to mention. You should not say minimal. Okay, because PSCs are very common in retinitis pigmentosa, and it is cataract surgery is indicated, as opposed to this much PSC in a normal patient you may not operate, but this is in RP even minimal is an indication for early cataract surgery. Okay, fine. Then correctable we were talking about. Then we will come to the macular findings in these patients, which will tell us one more correctable thing in retinitis pigmentosa. Okay, now he will tell us what is there at the macula. There is a shiny greenish membrane in the right eye, I'm assuming. The PSC is obscuring the details. Let's go to the left eye. Are you there, Tejas? Or
Yes, ma'am. Again,
can we go to the left eye now?
yes, ma'am.
So in any fundus drawing, this color coding is very, very important. There is something I published recently in Delhi Journal of Ophthalmology. It's a good article, if I may say so myself. It's very resourceful for color coding and drawing for all types of retinal pathologies. So if you go through it, you will see how to color code for everything. And you have to at least give, you have to write something in the patient name. You have to at least write MRD number. Names are of course not allowed. And date has to be written. And very, very ideally, the diagnosis has to be written. Provisional diagnosis has to be written. Then 3 things. One is IOP, phakic status, and gonio findings. These 3 findings are important in any fundus drawing. It may not be relevant to this case, but suppose there's a case of diabetic retinopathy, then that is like the prototype case for retina. 3 things. One is phakic status, IOP, and gonioscopy. I think you may have guessed why. Because if it's a PDR, then how do you treat if there is a cataract? So if there is pseudophakia, if there is aphakia, for example, gonio status to look for NVA, and IOP to know if it is NVG. So these 3 things, if you're able to elicit, even in a short case, like if you're so good at gonio that you can do it in a few seconds, then that makes your Amsler-Dubois charting totally complete. The date, the eye, as he has marked, a very good fundus drawing with proper color coding, and the 3 things that I mentioned with the provisional diagnosis. Fine. Here also,
Yes,
this PSC would have been seen on a distant direct ophthalmoscopy, so you should have mentioned that.
yes, ma'am.
So how does the PSC move on distant direct? I hope you know the
It will
meaning
move
of my
against
question.
the.
Yeah.
It will move against the
Why?
motion, movement.
Why? Gautami, quickly. Stuti, quickly.
Distant direct usually works with the principle of making the eye myopic. Like if it's a, so we are
Stuti,
essentially making the eye.
why does the PSC move the way it does? I think my network is bad, or I think. Am I audible?
Yes, ma'am.
Yes, ma'am.
So with the eye movement, how does the PSC move? Distant direct, how do you do? What are the findings of distant direct ophthalmoscopy if there is a PSC? Acha, you don't do direct ophthalmoscopy. Gautami?
Ma'am, we usually do at 1 meter distance. You have to focus there is any PSCC, there will be a central dark spot which is seen.
Okay. Okay, I just got a message that we have to conclude in 5 minutes. Okay. You please read it up, and if you can get hold of a direct ophthalmoscope which is rare in Joshi because we all do 90D and IDO. You can see what I asked about. Okay, next. Okay, go to the next slide. Okay, this is the OCT. What is there at the vitromacular interface? There is a
There is
hyperreflective
a
membrane.
hyperreflective layer at the vitreomacular interface, which collaborates our clinical finding of epiretinal membrane. There is loss of foveal contour, which makes it a grade 2 epiretinal membrane. The outer retinal layers are distorted with photoreceptor.
Central subfoveal disruption is there, and the parafoveal retinal outer layers are all lost. The outer retinal architecture in the parafoveal area is completely disorganized. This is the right eye. Left eye has, yes, the left eye vitromacular interface, there is a vitromacular adhesion to the temporal parafovea, and the foveal contour is maintained. Subfoveal layers are attenuated, and the parafoveal layers and the perifoveal layers, retinal layers, all of them are disorganized, especially the outer retina. Okay. The choroid is thin because you can see the choroid, I'm saying. Okay, next. So what does this patient have? So there is nothing called retinitis pigmentosa nowadays. It is for academic interest that I'm saying. But in the exam, you can say retinitis pigmentosa. Can you go to the provisional diagnosis slide? I'm just going to rush through and tell you what questions you may face in the exam. You can all make a note of it and find out. So, because I don't have much time, Mr. Amit has messaged that I need to wrap up in the next couple of minutes. As little as 2 to 3 minutes. So, retinitis pigmentosa is a cluster of findings, and there are more than 100 variants of it. So, we no longer call such a picture retinitis pigmentosa. It is of historic importance. However, you can call it retinitis pigmentosa in your exam. There is no need to use the word typical. You can say, considering the triad of waxy disc pallor with attenuated arterioles and bony spicules, this is seen in retinitis pigmentosa. You don't have to say grade 2 epiretinal membrane because the OCT will not be provided to you in the exam. It will be only after this this diagnosis that you have made. So saying grade 2 clinically is incorrect. And saying senile immature cataract is also incorrect because this patient is not senile. Senile immature cataract are terminologies used for patients who are in the senile age group and who have senile cataracts starting age 60, 65 and above. So I have seen many residents making this common mistake, especially when they refer a patient for B scan in a child or in a young adult, say with total white cataract. They refer as mature cataract for B scan. Mature cataract, immature cataract are terms used for senile cataracts, which are seen in the older age group. So in a 45-year-old, you have to specify that it is a posterior subcapsular cataract. You should never say senile immature. She is not senile. And the word typical is also not necessary. You can say it fits into the triad, so it is retinitis pigmentosa. So what is the next step for this patient? So first we have to quantify the vision loss. You have to do, like I said, a dilated retinoscopy. You have to do visual fields, and you have to quantify the vision loss. So you have to know about low vision, and you have to know about the visual disability classification. These are of academic and examination point of view. These are some things that they will ask. WHO classification of visual impairment, low vision, blindness, or legal blindness, all those set of questions is something that has to be prepared for this case. Second, you have to know about the visual disability. How much disability, like they come for disability certificate, for example, how much disability has to be quantified based on two things. One is visual acuity, how much it is in the better eye, how much it is in the worse eye, and visual fields. Okay. That brings us to the investigation of doing visual fields. Visual fields is very important in this patient to quantify how much field loss is there and how much of central vision is preserved. And visual fields are something that have to be done serially. The next investigation for this patient would be electroretinogram. Okay, and that is full field ERG. And you can do a pattern ERG also, but full field ERG is going to tell us whether it is a rod dystrophy alone or a rod cone dystrophy. So such a patient will initially have rod dystrophy where only the scotopic responses are affected. And later, as age progresses, they will also have involvement of the cones, in which case it becomes a rod cone dystrophy. That is why the term retinitis pigmentosa is of historic importance. What we call now is rod dystrophy, rod cone dystrophy, or cone rod dystrophy. Okay, this is if you have an examiner who is of retina background. Otherwise, RP is fine. Then how will you approach this patient? How will you treat this patient? You cannot say this is not treatable. You'll explain prognosis. Like I said before, you should treat the treatable reasons for vision loss. So if the patient has been having low vision in the night for decades together, they are very well adjusted adults by now. They know how to navigate their immediate surroundings. They are better than you in crossing the road in front of their house or in front of their workplace. They can even drive. They'll be having 5-degree, 10-degree vision, but they'll be still driving because it's all muscle memory for them. And their other senses are very heightened. So very well adjusted adults having recent deterioration is either because of posterior subcapsular cataract or macular pathology. So even in rod dystrophy, which does not involve the cones we usually say are concentrated in the macula, but still they can have macular involvement in the form of epiretinal membrane, like in this case, cystoid macular edema, degenerative cystoid macular edema, or macular thinning. These three things. In this, which two are treatable? A very adherent grade 3 and above ERM, you can in fact do an vitrectomy and ERM peel to reduce the symptoms of metamorphopsia and improve near vision in these patients. And second thing is cystoid macular edema, where you can give carbonic anhydrase inhibitors. Okay, and it's a degenerative edema, and the examiner can also ask you about causes of non-leaking macular edema on FFA. This is a prime example where there is no petalloid leakage despite there being gross edema. I'm asking the questions and I'm answering them myself because we don't have time. I'm not waiting for answers from you guys. Then, of course, about cataract surgery, this becomes an indication for cataract surgery with IOL. And very careful, good cataract surgery is done in these patients with minimal manipulation and very it has to be absolutely uneventful because they are very prone for pseudophakic cystoid macular edema, because they are prone for cystoid macular edema, these cases. And then the viva will inevitably go to low vision aids. So you should know that the principle of low vision aids is either to improve the relative size or the relative distance. You should know about all the optical devices, non-optical devices. You should know about visual rehabilitation. You should know about what else? Next very important thing nowadays is about which genes are implicated in what type of rod dystrophy and cone dystrophy. So you have to know about RPGR, RP65. Like if you're very good as a resident and answering really well, and the examiners of retina background, they may go a little more into gene therapy and what molecules are being used, what is the vector, which virus vector is used, and then they may go even into prosthetic implants, retinal prosthesis. So that is like the final destination of your viva. So if you're going so far ahead, then you can rest assured that you've done very well in the initial questions. So these initial things you have to sail through. You may just make a note of everything and read up. Any questions, you can message me personally. Our seniors, Jayashree ma'am and Anupama ma'am, can also contribute. Dr. Deepthi can also contribute.
One more thing is they will ask about syndromes associated with that is also one thing which
Very
we
important. Like hearing loss, for example,
Yeah.
Usher syndrome. What type of deafness? Is it prelingual, postlingual? First decade is Usher type 1, second decade is Usher type 2. Usher type 1 start walking at 18 months because their vestibular control is very poor. So there are a lot of syndromic associations. Bardet Beadle BBM, Bardet Beadle Moon. It's no longer called LMBB. It's Bardet Beadle Moon. They'll have obesity, hypogonadism, polydactyly. You have to ask about that. Then there is Ruffsome disease. That ma'am brought out a very important point. So syndromic RP, non-syndromic RP, very important.
And one more thing is atypical. Now you told typical is not atypical RPs. Atypical RPs. That also we usually ask in exams.
Yes, ma'am. Atypical is when it is not like the pigments are not, can be sectoral, can be periarteriolar. They can have without pigments. They can have only macular pigments. Some can have macular coloboma. So those are atypical.
And differential diagnosis for this thing. Pigments. Fundus picture, differential.
Yes. Can you tell any differentials? We call them secondary RP. Secondary retinitis pigmentosa. Due to what all?
Taxonol, that syphilis.
Yes, ma'am. Field choroiditis due to tuberculosis, syphilis, drug use, chlorpromazine.
And even trauma.
Trauma, yes. Spontaneously reattached retina. Old RDs which have spontaneously settled.
And one more thing is that this thing which we ask field defects in glaucoma and RP, how to differentiate. That is one favorite question of examiners.
Okay.
And Apurva, can we wrap up the presentation?
Yeah, sure.
Thank you, Apurva, for that wonderful presentation, the discussion with respect to the RP. And thank you, Dr. Tejas, for that presentation. I think it was really, even though it's a short case, the discussion was really helpful for you for your future posterior segment cases also, as to how to write a simple fundus diagram. The naming exactly becomes really important, and that is what was highlighted by our retina specialist, Dr. Apurva. And Jayashree ma'am, thank you for staying with us all this while, and thank you for all the inputs, even at the last moment. I think it's
We are also learners, so we
it's a really huge help from you to stay till the last part.
I
Really,
think we should have Jayashree ma'am and Anupama ma'am for every exam,
every case.
so that we learn so much from them. I learned so much today, really.
That's very true. So we are so stuck up in our niche that the rest of the department, something the basic, and so we end up forgetting. And thank you for really refreshing all our basics. So thank you, Dr. Apurva. Thank you, Stuti, Tejas, and Gautami. That was a wonderful feat to present on the first day. I think from henceforth, the PPGs will be well prepared as to what is going to happen. But today was an unknown area where you three have really ventured. So thank you, Dr. Gautami, Dr. Tejas, and Dr. Stuti. So with this,
Thank you,
Amit
ma'am.
and Navneet, thank you really for giving us this opportunity despite us crossing the time limit. So with this, I wrap up today's presentation, and tomorrow we would be coming up with 3 more cases and 3 more examiners. So all the best to all the postgraduates. The case list is already been put up on your I2I 2024 group. Please go through, do prepare yourself for the case presentation. All the best and good night, all of you. Thank you.
Thank you.
Thank you.
Good night and thank you.
Good night. Thank you.
Shall I
Good
end the
night and
meeting, ma'am?
thank you, and all the best for
Yes,
PGs.
yes, yes. Thank you.